Welcome to the wonderful world of clinical pain management. I'll be your conductor, Chris Herndon, for the next hour or two as we go through some fascinating clinical pearls associated with pain management pharmacotherapy. So, in all honesty though, let's talk quickly about the definition of pain. I know that you all had already discussed this with Dr. Schober and a little bit with Dr. Nieto. However, the definition of pain is reasonable to come back to, and it is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And that is from the International Association for the Study of Pain. Another good definition for this comes from a nurse out of California, Margot McCaffrey, who's probably one of the brightest minds in pain management today, and that is, pain is what the person says it is. Our learning objectives are pretty straightforward. I'll give you a moment to review those here, and you should have the slides available to you to follow along with. One thing we do need to know is that chronic pain is an incredibly large public health problem. And if you notice how prevalent it is, this is based off data from back in 2010. It is a little bit dated, but this is a survey that's done pretty frequently from NHANES and the CDC, and you'll notice that as many as 30% of US adults reported having pain in the last 3 months. So this is acute and chronic pain, not necessarily just chronic pain, but it is an issue. Pain is also a chronic problem when we look at it that way too. And if you look at this slide, basically what you're seeing here is that when we start looking at patients who are 45 to 64, or even 65 and older, a tremendous amount of these individuals will report having pain for 1 year or more. And I think that that is pretty dang staggering. This is another slide showing you a little bit about some of the limitations of activity and some of the disability that comes with the different common chronic diseases. And you'll notice mental illness, lung disease, diabetes, etc. And if you scroll down and look at arthritis and other musculoskeletal conditions, this can really become quite a huge problem for patients, especially as they get older. And you'll notice down at the bottom that the number of people that deal with this is just staggering. It's absolutely staggering. Hopefully you like my laugh and soundtrack. The other problem, and this is the one that probably makes me the most upset, is that pain is not adequately treated. And there are fairly evident disparities that do pop up when we start looking at data in a little bit more depth. Here's a good example, and I'd like for you to look closely at ages under 11 as well as over 65 years of age. And this is based on the amount of opioid analgesics that patients are given in the emergency department, all with a severe pain rating. So people who are under 11 are less likely to get adequate analgesia in the ER, as well as people over the age of 65. The other thing that's quite upsetting to me is that there's obviously ethnicity differences, which is also a pretty big problem in my mind. So let's talk real quickly about some of the different incidents that do occur. Cancer pain, when we pull it away from acute and chronic pain, is also pretty staggering. And unfortunately, as many as 1/3 of people that do have cancer will report some type of pain, with a huge proportion of those basically saying that what they were being given or how they were being treated was inadequate. So they were maybe being treated for their pain, but it just wasn't enough. And I think that's just a tragedy in my mind. The other thing that we need to do is we need to balance the ability to provide analgesia for these patients along with the risk of these drugs. So there are some problems with these drugs, and we have to be cognizant of those and monitor for them readily. This is something I think is very interesting. So when we look at 12-year-olds and older and look at the first illicit drug that they actually tried, you'll notice that the pretty predominant piece of pie on this chart is marijuana or cannabis. But very close behind that, indicated in the red, are prescription pain relievers. So it's on the rise, and it's certainly a problem that we all need to be relatively aware of. So how do we make sure that patients aren't undertreated, but that we're also not flooding the system with opioids that may or may not be appropriately prescribed? And I think that that's the big challenge right now, and I'm going to do my very best to try to cover off in some of these areas over the next couple hours. So let's talk a little bit about the definitions. Probably the one that's the most commonly misunderstood is that of addiction. And I think that for those of you who are going through the addiction elective, they'll have their own definition. For those of you that are in the pain elective, we tend to use our own. And then obviously in the psych neuro pharmacotherapy class, there's going to be ones that you're asked to think about there. What I want you to think about in terms of addiction in the pain management world, though, is that addiction is really the continued use of a substance despite known harm. So a patient continues to use a substance of any type despite knowing that it's causing them problems with either their personal or professional relationships, their school, their work, etc. And that's a bad deal. It's also associated with cravings, lack of control over use, maybe even ongoing use throughout the day. There's a lot of things that go into addiction. And in fact, we really don't call it addiction anymore. We call it substance use disorder. So let's contrast that with dependence. And dependence is basically a physiologic receptor phenomena. And so what's happening is that despite ongoing use, what winds up happening is that because of receptor changes that may occur at the cellular level, what winds up happening is that your body either quits producing its own substances that you may be giving it, or, and in the case of opioids, what winds up happening is that the way that the receptors complex with the opioids, you actually can have a withdraw effect when you abruptly discontinue the medication. And that can either be due to CAMP or changes in norepinephrine or dopamine. So let's keep going and talk about tolerance. Really, an easy definition for tolerance is needing more substance to elicit the same effect. Sometimes tolerance can be a little bit difficult to tease out in the pain management world because we either don't know that the drug is not working as well because of tolerance, or that there could be worsening disease pathology, especially in terms of cancer pain. Pseudo-addiction is a term that's really started to fall by the wayside as far as acceptability is concerned, but that's basically the display of addictive behaviors due to poor pain management. So a good example would be potentially you're giving a patient with awful chronic low back pain 2 hydrocodone tablets a day, but they really need 4 to function. And so maybe they start going to a second prescriber in a second pharmacy in order to make that up. Theoretically, if you do provide adequate pain management, that pseudo-addictive behavior should go away. Like I said, that's starting to kind of fall by the wayside. 2 other terms that we need to be pretty cognizant of are wind-up and central sensitization. Wind-up is something I'm pretty sure Dr. Schober discussed briefly in his lecture, but this is when the neuronal resting state actually does not completely reset. So it's easier to fire off neuronal depolarization or an excitatory potential. Why we get worried about that in the pain management world is that acute pain, that's a good thing. Wind-up actually is protective, and it may keep you from putting your hand on a stove twice in the same 5-minute period. Let's contrast that with central sensitization. So wind-up, I think you can say, leads to central sensitization, but that's basically where when you do start to move the neuronal resting potential back where it needs to be, that things don't reset all the way. And so there's a central response to this ongoing wind-up that can involve changes in neuroplasticity. It can involve changes in sodium channel. expression, and even types of sodium channels that are expressed or coded for. And what that basically turns into is pain that probably does not have a known etiology, or you can't image it or readily identify ongoing tissue damage, but the pain is still there. And so that's a good segue into nociception. Nociception is basically the normal conduction, transmission, modulation, perception, and transmission, if I didn't already say that, of a pain signal. So if you stub your toe, basically how the pain moves its way up the receptor and through the nerve and through the spinal cord and onto the cortex, that process altogether is called nociception. And the nerve fibers that actually conduct nociception are called nociceptors. So let's talk briefly about deafferentiation and neuropathic pain. Neuropathic pain, in contrast to nociception, is basically when you have damage directly to the nerve fibers. And this can be due to ongoing high levels of glucose in the blood. It can be due to chemotherapy. It can be due to a tumor or a spinal disc pressing on the nerve. There's a whole host of different things that can cause this. Now, deafferentiation, which is very similar to neuropathic pain, is usually due to the downstream signaling of the nerve being removed. So a great example of this might be phantom limb pain, or if for whatever reason a nerve is severed and the sympathetic ganglion or the dorsal root ganglion aren't receiving downstream messages, they'll make up their own sometimes, and that can result in ectopic pain signaling, and that can be a problem as well. We also want to talk about hyperalgesia. Hyperalgesia, easily defined, is something that should hurt that hurts worse than it should. Again, something that should hurt that hurts worse than it should. Allodynia, on the other hand, is something that should not hurt that actually does hurt because of central sensitization and rewiring. So a great example of this is a lot of patients that have diabetic peripheral neuropathy will experience allodynia, and what winds up happening is light breezes, light touch, a skirt or a bed sheet or a sock lightly brushes up against their lower extremity, and it causes excruciating pain for these folks. And that can really, really be a problem. Paresthesias is basically just an abnormal sensation, and so a lot of times we'll generically refer to some of these other sensations that way. The other thing we need to be very aware of is that there's a lot of comorbid psychologic issues that go along with pain. This number, 60%, is actually probably pretty low. It's probably closer to 80 to 90% of patients with chronic pain actually satisfy the DSM-4 revised criteria, and probably a similar amount for the DSM-5 criteria. So that's obviously a pretty bad, nasty thing.
We're sorry, your call cannot be completed as dialed.
And so that can really wind up being a problem with the communication that occurs, especially when we're trying to deal with taking care of these folks. So let's try to classify pain syndromes. So there's 2 or 3 maybe different ways that we can classify them. Probably the easiest way to classify them is by duration. So if you've had pain for less than 30 days, it's considered acute. If you've had pain for greater than 90 days, it's considered chronic. And if it's somewhere in between, typically we'll call that subacute pain. Now, there's a lot of folks out there that are basically saying that chronic pain should be defined as any time pain has outlived its usefulness, its protective nature. However, that can be kind of a problematic term, because you could argue maybe even with some of the orthopedic surgery injuries where there's a prolonged maybe 6 or 8 week pain syndrome that we really need potentially a third category here. We can also classify pain as either being nociceptive or neuropathic. And typically we'll categorize nociceptive pains as being inflammatory, which is an acute inflammatory reaction. Visceral, where it's coming from a visceral hollow organ and usually going through a referred pain type situation. Or somatic, and that's, you stub your toe, you get stung by a bee, whatever it might be. Like I said earlier, neuropathic pains are typically due to direct nerve damage, and those can either be further subcategorized as being centrally mediated. So the nerve damage is actually in the CNS versus the peripheral nerve system. Or they can be sympathetic. So it can actually be a direct result from faulty wiring between the sympathetic nervous system and the nociceptive nervous system. So those are some ways to classify pain. The other things that we need to keep in mind is that there are actually a number of different types of nociceptors that are involved. And I don't want to spend too much time on this because I know you've had a really good week of all of these things already from my pharmaceutical sciences colleagues. However, we do need to make sure that we're aware that there are different nociceptors that fire off based on different stimuli. So we have thermal nociceptors that basically respond to extreme heat or extreme cold. We have mechanical nociceptors, and that might be, the pain that you feel from giving somebody an Indian burn or something along those lines. It's actual mechanical stimulation. We have chemical nociceptors, and those typically respond to changes in pH. And so, the burn that comes with an acid exposure may actually be modulated by chemical nociceptors. And then we have silent or sleeping nociceptors, and those are the ones that are actually located within the dorsal horn of the spinal cord, and those kind of are just hanging out unless they're needed. And that's where things can get problematic because sometimes they wake up and start firing when they're not needed. And this can lead to chronic pain, which we'll talk about a little bit later. So nociception is a pretty complex problem. And I think that this is a really good illustration of what's actually going on. But you have the noxious stimuli, whatever it might be. And then you have these different receptors or channels that are triggered based on some of these different excitatory neurotransmitters or peptides. Once these things are triggered, they elicit a depolarization or a propagation of a receptor potential. So basically you have neuronal depolarization that conducts the pain signal down the afferent nerve. And this is propagated or produced by changes in sodium and potassium concentrations within the neuronal cell. So potassium can move in and potassium moves out. And like I said earlier, we can actually see an upregulation or downregulation in certain sodium channel subtypes based on what type of pain you're having and the chronicity of that pain. The dorsal root ganglion, which also has its own host of sodium channels, kind of serves as the pacemaker for the neuronal cell. And if for whatever reason it feels like it's not getting appropriate downstream signaling down here, it can actually produce its own what we call ectopic discharges. And so that can be the lancinating, unexplained pain that frequently will come from, for instance, again, diabetic neuropathy or even some of the cancer pains. Once we get down here, we have synaptic vesicles that are loaded chock full of excitatory neurotransmitters, primarily glutamate, and with some of the involvement of voltage-gated calcium channels, the regular calcium or ligand-gated calcium channels, and this little bad boy down here, the alpha-2 delta calcium channel, can actually change how quickly or how slowly these synaptic vesicles are released into the synapse. Once these are released into the synapse, and this is where termination and propagation to second-order neurons in the spinal cord occur, glutamate can either bind to AMPA, M-metabotropic glutamate, or NMDA receptors. And so this is kind of the chemical bridge, so to speak, that keeps that excitatory postsynaptic potential moving along. And so if you look here, we have a whole host of different areas that we might be able to use either analgesics, anticonvulsants, or antidepressants in order to elicit an effect. And at this point in time, you guys should all be going. So some of the different nerve fibers that we have alpha delta, which is actually the largest of the nociceptive neurons or the pain fibers. It's myelinated and very fast, and this usually produces that first onset pain. So if you look at first pain here, it kind of correlates to alpha delta and alpha beta. Alpha beta fiber is actually, alpha beta, the one located up here, is like touch. That's the fastest fiber. Alpha delta only carries painful stimuli. It is also myelinated, but not to the extent of the alpha beta, and it is what conducts first pain. And then you have the C polymodal fibers that conduct second pain, or that second order throbbing kind of late onset pain, okay? And the other reason that this is important is that these fibers synapse in different regions or locations within the spinal cord. So what you're looking at right here is a cross-section of the spinal cord, namely the dorsal root, or the dorsal horn, excuse me. And these different subsections are called laminae. And what's interesting is that the pain fibers traditionally will synapse in laminae 1 and 2. The light touch fibers will actually terminate or synapse in laminae 3 and 4. And then these C polymodal fibers, the long-lasting late onset pain, will actually terminate in laminae 5 and 6. And so where allodynia comes from, or that light touch eliciting painful response, is that central sensitization, when that occurs, you can actually start to see baby sprouts, or what we call baby neuromas, start to kick off of the light touch alpha beta fiber and can actually start to elicit transmission in these laminae 1 and 2, which are supposed to conduct painful signals. And it's kind of like the elevator at a large skyscraper. You know, not all the elevators go to the very top, and depending on which elevator you get on, if you think of these laminae as elevators that go up the spinal cord, it can change the way you perceive whatever signal they're transmitting. The other problem that comes with this, and I told you about peripheral and central sensitization just a second ago, but if you think back, peripheral sensitization is basically anything that allows the resting potential, or the neuron, to fire more easily. And this basically will result in increased nociceptor responsiveness. So it's easier to elicit a painful response. Another way to look at this is that if you put your hand on a hot stove, it's going to hurt a lot more if you go back near heat anytime soon. Even a bad sunburn could probably be categorized as peripheral sensitization. Central sensitization, on the other hand, are similar type processes that occur in the CNS, and there can be all kinds of things that go into this. You can have downregulation of descending anti-pain pathways, which can, and if you think of pain as being an on and an off switch, central sensitization can lead to a faulty off switch. You can see changes in second order neurons, and along with that, you can see changes in expression of some of those excitatory neurotransmitter receptors. And then remember I told you about those pesky little silent nociceptors that hang out. They can actually be recruited and start firing when there's nothing that needs to occur. And then I told you about neuroplasticity. So let's go in and talk a little bit about pain assessment. How do we tell if somebody is having pain? And it really can be a difficult thing to try to do, but we will try to work through it. You ready? Here we go. So pain impacts a number of different things. It impacts quality of life, activities of daily living, both basic and complex. It can affect your mood, your affect, how you deal with others, your relationships. Probably the thing that I see the most commonly as being problems for patients in my pain clinic are difficulties with sleep, ability to maintain activity and exercise, and probably most importantly, occupation or being able to earn a wage. There are some objective pain measures, but I want you to make sure that you understand that these objective pain measures are predominantly limited to acute pain. Those include pulse, respiratory rate, blood pressure, and diaphoresis or sweating. So if you have acute pain, acute sudden onset severe pain, you can see changes in these things. However, if these things are absent, it doesn't mean you don't have pain. And if you have chronic pain, you should not expect to see these things change necessarily, because your body reaches a compensatory state where it doesn't need these things in order to tell the rest of the body that there might be a problem. So probably the easiest thing that we typically will use in the clinical setting is the numeric rating scale, or the NRS. It's predominantly used when patients are greater than 9 years of age, although it has been validated a little bit lower than that. And it's easy. You basically rate your pain from a scale of 0 out of 10, and 0 represents no pain, 10 represents the worst pain. And something very similar to this might be the verbal rating scale, where you just ask the patient instead of giving them this little chart in order for them to fill out. The Wong-Baker-Faces rating scales are preferred in kiddos that are usually greater than 3 years of age, and then you just ask the child to point to the face they feel like is the most similar to what they're experiencing. And this can be a fairly accurate tool to use when you're trying to assess pain in a younger individual. We do have multi-dimensional pain tools. My favorite is something called the Brief Pain Inventory that actually has these nice little pain maps, and they're great because while the patients are in the waiting room, I can give this to them and they can fill it out and they can show me where they're actually hurting. And it's really interesting to see what some of the different things they mark on there, because it may or may not be conducive to what they're actually telling me. You know, they can draw zingers or they can shade it in. They can do all kinds of different things. So it's really kind of neat. For those people who can't communicate, and this is usually people with dementia or Alzheimer's disease, we have an assessment tool called the Checklist of Nonverbal Indicators. And really this is typically filled out by a caregiver, a nurse, an MA, or a certified nurse assistant. And there's a number of different questions that ask about these different things: vocal complaints, bracing, restlessness, and you're asked to rate those issues and then compile the results and score the pain based on that information. So let's take a quick break for everybody to kind of catch up with where we're at, and we'll be right back. Okay, hopefully you came back. Now I'd like to briefly go through the pharmacotherapy. Now I've changed the way that I plan on covering this year, because now that I know what's actually covered by Drs. Nieto, Schober, and then the depth or the level that you received some of these medications earlier in the course, we can jump right to how they're used in clinical practice. So the International Association for the Study of Pain has actually recommended that maybe we start calling these drugs different, because when we go in and we talk to a patient about, for instance, a anticonvulsant, in their mind they're thinking, well, I don't have epilepsy. Why do I need an anticonvulsant? I'm hurting. Or the selective or the serotonin norepinephrine reuptake inhibitors. Why do I need an antidepressant? I'm not depressed. And so that's why some of these things may be more easily called by what they actually do in the body in terms of pain transmission. Please don't try to memorize this table. I just thought it was interesting to share with you. So here are the drugs. And I think the probably easiest way to do that is to categorize or classify analgesics as either being opioids or non-opioids. So obviously we have a list of opioids on the left, and it's just opioids. And then we have a whole host of non-opioid analgesics on the right. And you'll hear different people call these things different things. You'll hear them called adjuvant analgesics. You'll hear them called co-analgesics. It just all depends on preference, but it's easier to just call them non-opioid analgesics. So let's focus on the anticonvulsants first. So the anticonvulsants, and this is focusing predominantly on the second and third generation anticonvulsants, you'll notice that we have a whole host of different utilities in pain. So if you look at, run through this real quick, you look at, most of them have animal data. Levetiracetam actually does have animal data, level 3 and level 4 data. It does not have ongoing data, and no level 2. And my definition of level 2 would be randomized controlled studies supporting their use. But if you look across, obviously gabapentin and pregabalin have level 2 randomized controlled study data. A relatively newer anticonvulsant called lacosamide does. Lamotrigine does, although some of its data is conflicting. Oxcarbazepine does. And topiramate, and zonisamide do. So these are the anticonvulsants that I tend to use in clinical practice the most. I'm really excited about perampanel. As you probably learned already in your epilepsy lecture, that is a selective AMPA antagonist, and I'm really excited to see how that pans out in the pain management world. There are some things we do need to worry about with anticonvulsants, and I think the biggest one for me is the dermatologic reactions. Hopefully this hasn't been the first time you've seen these terms in this class, but the way I want you to make sure that you think about these is that almost all of these anticonvulsants can actually contribute to Stevens-Johnson syndrome. Likely carbamazepine and lamotrigine are the worst. More importantly, or more severely, is the drug rash that is called toxic epidermal necrolysis, or TEN. And that's a very similar presentation, but just much greater portion of the body surface area. And then we have one called DRESS that I don't hear a lot of people talk about, so I thought I'd at least mention it. And that is drug rash with eosinophilia and systemic symptoms. And that can be a pretty nasty and potentially fatal drug rash as well. In most cases, these patients are all treated as if they have severe burns. Some things that I want to make sure that we talk about real briefly with the anticonvulsants are that most of them can also cause neurocognitive side effects such as cognitive dulling, word-finding difficulties, and there is a boxed warning on all of them that is a class warning that is potentially increased suicidal ideation. So let's jump right to the antidepressants. So I wanted to share with you just the antidepressants that we have some data supporting their use in pain, whether it's acute or chronic pain. So we obviously have the serotonin, norepinephrine reuptake drugs. We have venlafaxine, which is probably one of my faves. Desvenlafaxine, which doesn't really have good data in pain, but it operates almost the same as venlafaxine does. We have duloxetine or Cymbalta, which you guys are obviously all familiar with. That has numerous pain and non-pain indications. We have milnacipran or Savella, which actually usually doesn't show up in the antidepressant categories because it's only indicated for fibromyalgia. However, I put it here because it does have the same mechanism of action, and that's further supported by its Me Too sister that came out recently called levomilnacipran or Fetsima, which is indicated for depression, however not for fibromyalgia. Almost all of the SNRIs can cause some elevation in blood pressure. Venlafaxine of this crew is probably the most activating and should be given in the morning. And duloxetine, while it can go either way, typically in our clinical practice, we see it usually follow a more sedating profile. The other thing to keep in mind with duloxetine is that it actually probably does need LFTs monitored on that particular medication, so keep that in mind. Your atypical antidepressants, which include bupropion, mirtazapine, trazodone, and vilazodone, all have varying levels of data to support their use in pain. For bupropion, it's limited to 1 or 2 randomized controlled studies in the treatment of diabetic peripheral neuropathy. Mirtazapine does have some scant data in migraine prevention and some poorer, really not well-controlled studies looking at its use in diabetic peripheral neuropathy and postherpetic neuralgia. It's really not one that we typically will go to because the side effect obviously is weight gain with mirtazapine, and in most of our pain patients we don't want them to gain weight. Bupropion we will use because obviously there is some weight loss associated with that, but you do have to be worried about seizure disorder with that medication. Excuse me. Trazodone has positive data only in high doses and only in the treatment of fibromyalgia. Vilazodone, which looks very similar to Vibrad, is currently under investigation, but does not have, I think, enough data to really support its use in the treatment of pain. Probably what the drug class that has the best level of data in its use in the chronic pain world are the tricyclic antidepressants. So I have them listed here in 2 different ways. I have the tricyclic antidepressants listed both as tertiary and secondary amine tricyclics. And remember that tertiary amines tend to have higher lipophilicity They tend to cross the CNS much more readily and can cause more CNS side effects, more postural hypotension, and they can also have elevated anticholinergic side effects as well. Now, the other thing I want you to notice is over on the right, this is the order of binding affinity for the H1 histamine receptor. And so a lot of the sedation that comes from tricyclic antidepressants can actually be attributed to their activity on the histamine 1 receptor. And so doxepin, which has the highest, is frequently considered to be the most sedating of the tricyclic antidepressants, while desipramine, which has the lowest binding affinity, is thought to have the lowest amount of sedation with tricyclic antidepressants. And so we tend to pretty much see this very continuum in clinical practice. Now, I've told you all on several occasions that I don't think SSRIs, or selective serotonin reuptake inhibitors, are really beneficial medications in the pain management armamentarium. Now, I do have to put a preface on that we do have two of the SSRIs that do have some reasonable data. One of them is paroxetine, which is shown in one, maybe two very small randomized controlled studies to have some effect in various neuropathic pain conditions. And then we have a really interesting study that was conducted with escitalopram or Lexapro probably about a year and a half ago, where it compared escitalopram to duloxetine in the treatment of radicular low back pain. And what they found is that escitalopram was non-inferior to duloxetine. So really not a lot to hang its hat on, but it does raise some interesting questions. I think it's also a good idea that we talk about muscle relaxants and where they may fit in. I'll tell you that my favorite muscle relaxant clinically is baclofen. It tends to be probably the easiest tolerated of all of these medications, at least in my clinical experience. Baclofen probably also has the largest set of data to support its use in the acute and chronic pain world. Now, you do have to take that with kind of a grain, because most of baclofen's data is affiliated with its use intrathecally and not orally. But if we run down the list here, you'll notice two chemical structures. The one on the left is actually amitriptyline, and the one on the right is cyclobenzaprine. So you'll notice very, very little difference between those two structures. And cyclobenzaprine really does behave like a tricyclic antidepressant. It has a lot of anticholinergic side effects. It's very sedating. It can cause QT, prolongation. So it's not a great skeletal muscle relaxant. And remember that with the exception of probably baclofen, none of these other drugs really have data beyond 3 weeks. And so it's kind of tough to justify their ongoing use. Yet, if patients are actually deriving benefit from them, and we can keep them off of an opioid by providing long-term cyclobenzaprine or baclofen or what have you, then not a bad way to go. Metaxalone or scalaxin is considered to be the least sedating of the skeletal muscle relaxants. Clinically, I also probably find it to be the least effective of the drugs as well, based on patient response. We have two other older skeletal muscle relaxants, methocarbamol and orphenadrine. Both methocarbamol and orphenadrine are incredibly sedating. Orphenadrine, in comparison, though, does have some activity at the sodium channel, and so there may be some theoretic utility in the use of that drug for some of the mixed pain syndromes. We will also use tizanidine a great deal. Tizanidine is a centrally acting alpha agonist, very much like clonidine, and so you have to worry about dropping patients' blood pressure when you put them on tizanidine. You also have to worry about abruptly discontinuing it and developing a rebound hypertension effect. When we look at these drugs and we compare them as a whole using systematic reviews, really these drugs are no more effective than NSAIDs, and probably we can't, based on evidence that we have, we can't really recommend their use chronically for chronic pain conditions. So that brings us to our NSAIDs. So a lot of these drugs probably look very familiar to all of you. I'd like to point your attention over to the non-acetylated salicylates, because these drugs tend to be overlooked very frequently. They're not nearly as potent as anti-inflammatory drugs as these other four classes. And what's interesting about these drugs is they have very low activity at both cyclooxygenase 1 and cyclooxygenase 2. And what we're maybe thinking these days is that these drugs elicit their analgesic and even potentially anti-inflammatory effects via inhibition of tumor necrosis factor alpha to a very, very weak degree. One of the reasons that we like these drugs, especially in the hospice world, is they have very little effect on platelets. So much so that the American Heart Association has actually come out recently and actually recommended non-acetylated salicylates in patients that we think are going to be at relatively high risk for cardiovascular disease. The other thing I want to point out when we're looking at these 5 drug categories is that each of these should be almost considered its own separate drug class. So if you've been taking ibuprofen or naproxen and both of those drugs don't work, please don't assume that all NSAIDs don't work, because there are structurally different NSAIDs that may actually provide some benefit to the patient. And so don't necessarily throw the baby out with the bathwater if you're going to say, no, we're not going to do any of these anymore. So one other thing that I think is important to note is the bleeding risks that come from these NSAIDs. It's predominantly COX-1 mediated, so that means that the more COX-1 mediated or the more COX-1 selective an NSAID is, the more likely you are to have bleeding problems. And for the longest time, gang, what we thought is that the bleeding and the peptic ulcers came from the acidic nature of the drug sitting on the stomach mucosa. That's not the case. It's actually almost completely prostaglandin mediated. Remember, these drugs inhibit prostaglandins, and prostaglandins can actually form the protective layer in the stomach. So if you inhibit that, you're basically allowing the stomach to digest itself. The other thing I think is important is, so we talked about the COX-1 selective drugs. Now we need to talk about the COX-2 selective drugs and some of their problems. Now remember that both COX-1 and COX-2 NSAIDs can affect renal function and elevate serum creatinine. So don't think that one set of drugs based on their selectivity is more safe for renal compromise than the others. But if we talk about cardiovascular risk, without a doubt, the more COX-2 selective a drug, the more likely it is to cause negative cardiovascular outcomes. And we saw that firsthand when Vioxx or rofecoxib was taken off the market some years ago. That was probably one of our most COX-2 selective drugs. So obviously the COX-2 selective drugs have lower risk of bleeding because they don't affect the platelet as much and they don't affect the stomach lining. However, COX-2 selective drugs will actually inhibit prostacyclin or PGI2, which really serves as your body's natural clopidogrel. And so by inhibiting that, it actually sets your body up to actually kind of sit within a pro-thrombotic state. And that can obviously be a problem. The American Heart Association, and they know something about heart stuff, have come out and basically say they consider naproxen to be the safest NSAID in the general population. However, in those with cardiovascular disease, if you absolutely need analgesia, they recommend a non-NSAID first. And after that, if you still need some mild anti-inflammatory properties, they recommend a non-acetylated salicylate. The College of Rheumatology, they didn't want to get outdone, so they came out with their own guidelines, and they basically said, yeah, we agree with those guys. When we talk about heart failure, that's a whole different animal, and we really should have all NSAIDs stopped for 2 different reasons. And obviously, this excludes aspirin. First and foremost, NSAIDs can increase your risk of conversion from heart failure into both ventricular arrhythmia and fatal MI. And the other thing is that a lot of patients that have heart failure can actually be volume depleted intravascularly. So I'm not necessarily talking about patients that have early heart failure. However, if you are intravascularly depleted and you put somebody on an NSAID, you're basically begging to put them into acute renal failure. The other thing when we're talking about ACS or acute coronary syndrome, again, the heart folks came out and said if you come upon somebody that you believe either has had or is having or recently had a myocardial infarction, a STEMI or a non-STEMI, stop all non-aspirin NSAIDs immediately. And if you absolutely have to start one back up on discharge, naproxen's probably the best if you can't get a hold of the non-acetylated salicylates. So if we talk about the actual guidelines from the joint guidelines from the arthritis guys and the gastroenterology guys and girls, they basically talk about risk categories and recommendations. So if you have a low risk category, and that means low risk for both GI bleed as well as low risk for cardiovascular disease, you can use just a plain old non-selective NSAID, but they still recommend low dose and low duration. Intermediate, obviously they have their own recommendations that include either traditional NSAID plus a proton pump inhibitor, misoprostol, which is Cytotec, or high dose H2 or histamine 2 antagonists. There's obviously some other methods that you can do in order to try to limit risk. For high risk, they basically will recommend avoiding NSAIDs altogether, or they'll talk about using celecoxib and a proton pump inhibitor if the GI risk is higher than the CV risk, okay? If there's a lot of GI or CV risk, they recommend naproxen plus a PPI instead of the celecoxib plus the PPI. So I know that's a lot to take in, but this is a very important table because it'll really guide a lot of what you do and a lot of the recommendations that you make on your APPEs next year. So I was talking about selectivity. So this is actually probably the best way I can think of to actually show you the different categories instead of putting all the drugs up there and putting them on a continuum. But when we talk about what we would consider to be the more COX-2 preferential, that's the term that I prefer. That's 55 to 50-fold COX-2 preference. We have a Totolac, which is Lodine, Meloxicam, which is Mobic, and celecoxib, which is Celebrex. And so remember that Celebrex is not the only COX-2 selective drug that we have left, if you really want to call it selective, because there's still some COX-1 selectivity there. Less than 5-fold COX-2 preferential, so this is what you would consider to be, they do both, but a little more COX-2 than COX-1. We have diclofenac, which is Voltaren, Sulindac, which is Clinaril, meclofenamate, which I would almost guarantee nobody is going to ever see again, but it's still available, piroxicam, which is Feldene, and diflunisol. Remember, diflunisol is actually one of the non-acetylated salicylates. From a COX-1 preferential category, obviously we have some of the more traditional NSAIDs that you all are probably used to seeing, with the most COX-1 preferential being ketorolac. And so that's important to remember. Recall that ketorolac, you can only use this drug for 5 days in a row, and that's predominantly to keep you from frying your kidneys and putting a hole in your stomach. So let's keep chugging. Let's move on to opioids. What you're looking at here are obviously the opium poppy plant. And it's really kind of interesting when they go to milk the actual opium elixir from these. What they do is they wait until it's ready to harvest, so they'll flower and then the flower will fall off. And then these guys with what look like Freddy Krueger gloves will come along and they will scratch or cut the side of these things, you know, like this, and then this white latex, very viscous white latex stuff will ooze out, and they'll scrape it off and let it dry, and that's what becomes opium, pure opium tar. So let's talk about some of the adverse effects of opiums, or opioids. So both Dr. Nieto and Schober talked about the differences between opiates and opioids, so I won't go over those. What you do need to know about are some of the adverse effects of these drugs, and they're basically broken down for you. Without reading through this slide in its entirety, if you want to pause the presentation and maybe read through it, that would probably be the best way to keep this from becoming too long. But I do want to point your attention to some of the CNS side effects that include respiratory depression. Remember that respiratory depression is most pronounced when you're first starting one of these drugs, when you're escalating a dose, or if you are on other respiratory depressant medications like a benzodiazepine, or if you have respiratory depression related disorders like COPD or obstructive sleep apnea. The other things that we need to keep in mind are the dependence and substance abuse issues, as well as sedation. And sedation typically you become tolerant to, such that a lot of these patients will report that really it doesn't cause them much sedation at all. The other big one that we really need to know about is the constipation. And I'm moving on down to gastrointestinal. If you put somebody on an opioid, you need to put them on a stimulant laxative. It's very important. That can be with or without a stool softener, but you really have to have a good bowel regimen in place. And we also need to proactively anticipate nausea with these drugs. You will not get tolerant to the constipation. That's something that if you get it, you're going to be dealing with it unless you change the drug or you treat it. With nausea, though, a lot of times you'll actually become tolerant to the nausea and be able to tolerate the drug a little bit better. Maybe not as common as some of these others, but one I see a lot is urinary retention, and then moving on down, we see pruritus. And it says that that's a side effect within the integumentary system. However, it's really not a skin issue necessarily. It's actually a CNS issue, because the pruritus is modulated via the nervous system and not because of necessarily a direct irritation to the skin. So you may be itchy all over. You may not actually have a rash. A lot of patients will actually describe that as an allergy, but it's really a side effect of the drug. And we're not absolutely sure what it comes from. A lot of people think that it comes from mast cell lysis and histamine release, and will correspondingly treat with an antihistamine. However, we don't really have a lot of good data to support antihistamine's use for opioid-induced pruritus. What we do have good data for are opioid antagonists, so either naloxone, or we'll even use some of the mixed agonist-antagonist drugs like nalbuphine to actually treat or reverse pruritus. Some of these other ones I think are not as common, but I will see in higher doses some of the metabolic side effects that can include prolactin changes. The loss of libido is predominantly due to hypogonadism, and that is opioids will actually reduce the activity and the release of gonadotropin releasing hormone. And so what winds up happening is that you can see a decreased circulating free testosterone in men and in women, and also in women decreased follicular stimulating hormone. So that brings us to the opioid-induced hypogonadism. So I just talked a little bit about some of the hormones affected. In men, you're obviously going to have impotence and loss of libido. Men can also experience infertility as well as women. Usually we see more fatigue, depression, and anxiety associated with hypogonadism in women, and more loss of muscle strength in men. So obviously there's some big issues that go around opioid-induced hypogonadism. The big controversy now is, do we treat it with hormone replacement, or do we reduce or change the drug? And unfortunately, I don't have a good answer for you, and a lot of people will do things differently. There are a group of us that are trying to get together and put together some practice guidelines around this, and hopefully those will be out soon. Another big one that's really been a hot topic lately is something called opioid-induced hyperalgesia. And I don't know that I heard any of my colleagues talk about this, so I'd like to spend a minute on it. And basically what this is basically attributed to is what we think might be opioid-induced neuroexcitation. So if you're on opioids for a long period of time, most of the opioids, with the exception of methadone and levorphanol, can actually serve as NMDA agonists. And remember, NMDA is a receptor for glutamate, which is excitatory. So if we're actually stimulating NMDA with some of these analgesics, we can actually be making pain worse in these patients. The other thing we found is that chronic high-dose opioid use can actually make your off switch or your descending pain pathway operate poorly. And so your body can actually lose its ability to naturally modulate its own pain signals. The thing that I want you to make sure that you can differentiate between is the difference between opioid-induced hyperalgesia and tolerance. Tolerance is the need of more drug to get the same response. So the drug worked at one point in time, now it doesn't work, and you need more for it to work again. Opioid-induced hyperalgesia, typically the drug never worked, and as you increase the dose, the pain doesn't get any better, it either stays the same, it gets worse, or it can change characteristics entirely. And we will see this once in a while in the clinical service. I talked about opioid-induced pruritus already. Like I said, we're not really sure if it's mast cell mediated or mu opioid receptor mediated. We do treat it with antihistamines, but we really don't have a lot of data to go on. You will see some of the children's hospitals actually using low-dose nalbuphine or Nubane, or low-dose, very low-dose infusions of naloxone. And then we talked about opioid rotation. Dr. Ferguson taught that in my pain class. I'll briefly cover it in this lecture for the therapeutics course. We also need to talk about opioid-induced constipation. This is a direct neural inhibitory effect on the myenteric plexus. So this is a nerve blocking effect. And what we really need to be able to do is to have nerve stimulants that actually push the feces through. And it's important that everybody remembers that you need push with the mush. You need a stimulant laxative with a stool softener or without a stool softener, but you do need a stimulant laxative. Because if you think about it, the myenteric plexus is responsible for peristalsis. That's what moves everything along. So even if we load somebody up on a stool softener, it may get mushy, but it may just sit there. We do have good data on the stimulant laxatives. We have good data on polyethylene glycol or Miralax. And we also now have what are called PAMORAs, or peripherally acting mu opioid antagonists. And the two that we have right now are methylnaltrexone and naloxegol. So methylnaltrexone is Relistor, and naloxegol is a drug called Movantik. Opioids can also cause respiratory depression, as I had noted earlier. And I told you a little bit about some of the different areas that we need to be concerned about.